We have been interested in thalidomide and lenalidomide for over a decade. Thalidomide was the controversial drug that had teratogenic effects. But when we did a clinical trial on thalidomide, we found that it was very poorly tolerated, a lot of side effects, a lot of toxicity. So we abandoned that because we couldn't get to the target dose. Why are we choosing these two drugs, and lenalidomide being an analog of thalidomide? Because lenalidomide and thalidomide are both potent TNF alpha inhibitors and BACE inhibitors. And so when we found out that thalidomide was not well tolerated, we ended up doing a clinical trial on lenalidomide, which is its analog, with the idea that it would have better tolerability, lower toxicity. So again, being a potent PNF, have robust anti-amyloid and anti-inflammatory effects. Got great reviews in grants, both for ADDF grant and our NIH R01. And we're now doing a clinical trial. And the design of the clinical trial is mild cognitive impairment due to Alzheimer's disease, proven by a biomarker confirmation, and then randomized either to 1-to-1 to Alzheimer, to lenalidomide or placebo. The first one, what's known as MCLENA-1, which is the mild cognitive impairment lenalidomide. MCLENA-1, which is the one I'm presenting at the ADPD, is 1-to-1 randomization, 15 in each arm, phase 2 trial, IND already approved, and followed for a year. We're looking at imaging biomarkers, PET and MRI, and a little bit on the blood side, but and safety, of course, and cognition. So there are 2 trials going to be going on back to back. Study is enrolling, so all I can tell you is that we have screened, I think, 10 and enrolled 6. Our total target is 30, and they all meet criteria for mild cognitive impairment due to Alzheimer's. And I can tell you that the baseline data is very early because it's only been 6 patients out of the 30 enrolled, 30 that are targeted.